Okay, everybody, this is Dr. Ed Park. Thank you for joining us. We're doing a webinar on the shoulders today. This is one in a series. Last week we did the back. Next week, I think the knees, and in 2 weeks, the hips. When we talk about the scope of the problem, about 70% of people have significant shoulder problems or pain in their lifetime. About half of those people, the pain persists more than 12 months. So it is a significant problem. What leads to that? Well, there's injury, there's aging, there's poor posture, actually, I've been learning. If you slump forward, it puts the shoulder out of alignment. That can contribute. And then weakness in the rotator cuff muscles, which are really should be considered as fine postural muscles, keeping that ball in that socket. The reason I resurrect this slide all the time is that it's illustrating a very important point that because the shoulder, like the back we discussed last week, is made up of cells, and cells are made from stem cells, and they come in various varieties like muscle, bone, cartilage, ligament. They're subject to the rules of biology, and the rules of biology say that as a cell copies, it is going to shorten its telomeres. If they get too short, chromosomal rearrangement happens, there's damage. Also, a truism is if you copy the software, the epigenetics, you also get dysfunction. So what I'm trying to assert here is that all these other diseases are really just one main disease, genetic, but also epigenetic dysfunction. Let's get one thing out of the way. There's referred shoulder pain because the dermatomes, or the skin areas innervated, also include the shoulder. So if you have an impingement on your cervical nerve root, you could also think of that as shoulder pain. That's how it would manifest. For example, if we look at this dermatome chart, the blue stripe is C5 going down to the thumb. If you have shoulder pain there and it radiates down to the thumb, you're looking at C5. Where you can test this, you don't have to have a doctor smushing down on your head, as in the Sperling test. I gotta learn how to do the weatherman thing. Okay, Sperling test. What you can do is just rotate your head to the side and then tilt back, and if that reproduces or exacerbates the pain, you probably have a nerve root impingement. If you want to learn about nerve root impingement, go to last week's webinar on back pain. Therein we discussed discogenic ligamentous and also poor alignment or spondylolisthesis as a cause of root pain. One of the reasons I moved to Hawaii is because I had such great support from my friend Akimi. Akimi, this is not her radiograph, but it's similar. She had a whiplash incident where neck spasm was pulling on the cervical spine and causing shooting pain down her arm. After one nasal injection, interestingly, that resolved. Finally, you can get neurogenic shoulder pain or referred pain from this brachial plexus injury. The brachial plexus are the lower nerve roots that come out of the cervical spine, and they pass under the clavicle where they're sometimes impinged or pinched. To test this, you put your hands up, rotate your shoulders back a bit, and go like this for 3 minutes. If this Rouge test is positive, your hands will get numb or heavy or painful. So we've gotten that out of the way. Shoulder pain can be from nerve root impingement. Let's get to the shoulders. The shoulders, what are they? Well, we have the axial skeleton shown, oh, I'm getting better at this, over there. Blue skull, blue backbone, and blue ribs. This is the axial or central axis skeleton. Down below, we have the pelvic girdle, which of course controls the motion of the lower extremities. And above, we have the shoulder girdle or pectoral girdle, pectoral meaning chest, controls the arms, okay? So there's three main bones. There is the long bone of the arm, and then we have the collarbone connecting to the sternum or breastplate, and those both are touching the scapula. The shoulder blade is the scapula, okay? So as we look at the anatomy above, we see a flat area on the front surface, and on the back, there is a ridge going across. This is the spine. Now, the spine, it has an underpass. So you can see this from the front a little bit. It's not a solid ridge, there's an underpass, and under this passes the rotator cuff muscles, as we'll see shortly. Some landmarks that will be needed for the rest of this talk are that knob in the front is called the coracoid process. It happens to be fused in humans, although not in all animals. So there's three bones of the shoulder. If we look at that spine, it turns into a little J hook when it kisses the clavicle. That J hook is called the acromial process. So all the muscles, ligaments, they're all named after these things. Coracoid, acromion, and also the glenoid just means the neck or the socket of the shoulder blade. Yeah? Okay. You'll all be experts in shoulder anatomy soon. So let's look at the muscles of the shoulder from the back. We have these powerful muscles, the trapezius attaching to the spine and this ridge, which we'll talk about, and then the deltoid, which is this delta-shaped triangle muscle that adducts. Adducts means lifting the arm away from the body. And then the third of four, well, more than four, but the third big muscle moving the arm is the latissimus dorsi. That's that swimmer's muscle that will allow for extension of the arm. So the first two insert on this ridge, okay? In the front, the deltoid and the trap insert on the clavicle. At the side, they insert on the acromion, remember the acromial process. And then on the back, it inserts on the spine. These are the muscles that do the heavy lifting, quite literally. The rotator cuff muscles are more, as I said, postural. They keep the ball in the socket. And those are the ones that are usually injured, not these big muscles. Okay, so we have the big muscles moving the arm. Let's peel those back and look. And you can see here, the shoulder blade has muscles. The levator scapulae goes up to the base of the skull there, and that'll lift the shoulder blade. We have these two rhomboids, rhomboid minor and rhomboid major. And then we have 3 or 4 of the rotator cuff muscles. We have the supraspinatus for adduction, and we have the infraspinatus / teres minor, which allow for external rotation. Pictured here also is the long head of the tricep, which allows for extension of the arm behind you. Okay, what this gentleman is demonstrating is a winged scapula. You can imagine that if the rhomboid minor or the rhomboid major, or as we'll see in a moment, the serratus are not working or damaged, you can get a wing of the scapula. Anteriorly, we have the fourth of the rotator cuff muscles seen over there. There's the subscapularis. On the anterior surface, okay, the front surface of the shoulder blade, this will attach to the long bone and allow for internal rotation of the arm. You also have a little muscle, the coracobrachialis, and then on the other arm, it's shown the bicep, which allows for, of course, flexion of the arm and the lower arm. And we have the serratus anterior, which are these little muscles. Sometimes models are accused of being too thin when they have powerful serratus because it looks like their ribs are sticking out. Those will wrap around the back and connect to the medial side, the middle side of the shoulder blade. I put this here above to illustrate an important point. If you have a samurai sword and you cut a tendon, okay, it's going to retract back. It's less likely for that to reconnect because the muscle contracts and there's no bridge. But it's not that it couldn't happen, it's just less likely. You might need surgery there. More often than not, we get a partial thickness tear, which means that there is damage. We get perhaps tendinitis, irritation, and we get maybe a fluid-filled or weakened area as that heals and is in pain. Over the course of a lifetime or too many copies, too many stem cell attempts to reproduce the tendon, we get tendinosis. And tendinosis is a phenomenon which means that there's no more copying going on. It's burnt out. It's not the same elasticity or quality. That's bad. And that's part of what contributes to decline throughout the body. It's important you understand what the bursae are. I don't know if I'm saying that right, bursae, but the bursae are these gel-filled packs which lubricate the motion of the ligaments, tendons. It's a very brilliant design. On the right, we see the knee has some bursae. Now, I had a patient tell me, oh, you really should use ultrasound to find knee injection. And I said to her, well, I took a 2-day course in anatomical and ultrasound guided injections of all these joints. And what they taught us is that only 85% or 85% of the time, if you inject into the easy pouch up there above the kneecap, it won't connect, or it will connect. But 15% of the time, the knee won't get what you're injecting, whether it be steroids or exosomes. So I prefer to use a palpation technique. It's very much better, as we'll discuss next week. In the shoulder, our target is going to be the subacromial bursa. Below the acromion, there's a pouch, and under that pouch will pass the rotator cuff ligaments. So presumably, we inject in there. As I'll show, it's quite easy to do, and it'll leak out and heal the structures we want to heal. Finally, we'll talk about the acromioclavicular joint. It's not a joint per se, hence the quotes. The joint is really the union of that J hook and the collarbone at a ligament. This can be traumatized, of course, by falling or even by excessive weightlifting. The way to test this, you don't need a band. You can just interlock your fingers and pull apart. Of course, you can see that the mechanics of that causes both acromia to separate. If there's pain elicited on one or both sides, you may have irritation or ligament inflammation in the acromioclavicular joint. All right, getting to the shoulder proper. The shoulder is a classic ball and socket type of joint. And what that means is that we want to have a nice, beautiful Teflon coated white capsule of hyaline cartilage, smooth, tough cartilage. And that sits in a socket of smooth, tough cartilage with a nice reinforced rim. Over the course of years or damage or aging or all the above, we get damage to this joint. This is illustrated in this radiograph above. What we're not seeing here is a wide gap between the ball and the socket. That black line separating them should be thicker because the cartilage should be thicker. This represents osteoarthritis or simply degeneration of that thick, beautiful Teflon cartilage. What's also seen here is poor alignment. The ball is not sitting well in the socket, and we have these spurs, bone spurs above, bone spurs below. These are called osteophytes, perhaps caused by trauma, inflammation, misalignment, all the above. And this is kind of the final common pathway of symptoms, exacerbating the problem, causing more damage to the tendons, and leading to problems. We're going to work our way out from the ball joint now. And what we see here is that the socket of the glenoid, or the neck, or whatever you want to call it, the holder of the ball, has a rim around it, just like the knee has a menisci that hold the tibia in. If this rim of cartilage is damaged, then you have a problem. Two common problems are the SLAP lesion, that's the superior ligament from anterior to posterior. What that often happens is that the bicep tendon will tear off. It'll peel off, as shown in this lower picture, causing pain in that labrum. There's also what's called a Bankart lesion, which is if you get repeated anterior shoulder dislocations, then you can tear down at this 4 to 6 o'clock area. One test for this is maybe not that sensitive, 70%, but if you have the person extend their arm out and then internally, adduct the arm, then you can have them turn their thumb down. And it's empty can test or Job test. These names are silly, but have them lift against resistance. That'll create more tension in the labrum. If there's pain, you could be talking about a labral tear. In contradistinction, if they turn their hand up, supinate like that, and there's no pain, there is some predictive value to say that that is not a labral tear. That's the O'Brien test. Okay, we're working our way out. Remember, so we have the ball and socket, we have the labrum, and then we have this ring of ligaments. Ligaments are that tough, leathery, sinewy fibers that join bone to bone. That's the definition of a ligament. A tendon, the definition is muscle to bone, okay? So the names are less important to us. All you have to know is that the entire ball joint is encapsulated by these ligaments. They have names, superior glenohumeral ligament. Gleno, you know, is the neck. Humerus is the long bone. Middle glenohumeral, inferior glenohumeral. Okay, that's of very low interest to us. All we need to know is that proper alignment and function of the shoulder requires the ball sitting in that socket, surrounded by a tight labrum, surrounded by tight ligaments. And around them, what we do see here in the picture are these cut muscles, and those are the rotator cuff ones that we'll get to. When you have long-term damage, let's say repeated dislocations or other processes, you can get an unstable shoulder. An unstable shoulder is a loose shoulder. We test this. The doctor will come behind and push down. If there's movement, then pain, then that could show anterior inferior capsule problem. That makes sense. A doctor could stand there and lift your shoulder joint up and down. That's called a drawer test. That's indicative of anterior and posterior capsule instability, also making sense. If I walk up to you and pull down your arm and then a sulcus or gap appears between the clavicle, if it appears between the acromion and the arm, then we have a sulcus sign. That means that there's superior capsule instability. And if you have, say, a veteran pitcher at the end of his career and maybe he has laxity or, God forbid, joint dislocation, maybe a snowboarder, you can get MDI, which is multi-directional instability. That's also bad. And shoulder dislocation is shown here. You can imagine that repeated locations can cause that Bankart lesion, tearing off at 4 to 6 o'clock of the labrum, but also it will loosen up those ligaments, and we have an unstable joint and then a sulcus sign. Finally, one thing people complain about is a frozen shoulder. Some people use that as a jargon, but actually a frozen shoulder is a specific syndrome according to medical science, and it is called adhesive capsulitis. And this is a bad condition. It generally runs 6 to 12 months or more. There are 3 phases. One is the freezing stage, where whatever inflammation, fibrosis is occurring is painful, and your range of motion is limited. Then there's the frozen stage, where there's not as much pain, but you just can't move it. It's frozen, hence the name. And then hopefully after that comes the thawing stage, where whatever badness that occurred is corrected and you can start moving again. Physical therapy is great. In fact, when you compare it to placebo, you compare physical therapy to steroid injection, the long-term outcome is no different according to randomized controlled trial. So what causes this? Well, no one knows. Prolonged immobilization, like say you had breast cancer or a broken arm and you didn't move it, can cause it to freeze. It's associated with diabetes, thyroid disorders, but basically the reason it's happening is there's inflammation, there's fibrosis, something bad's going on there. And I have to say that if I had to design a FDA clinical trial for exosomes, this would probably be a good candidate, low-hanging fruit, because exosomes decrease inflammation, and they reduce scarring and promote regeneration. All right, let's get down to the rotator cuff. So we talked about I forgot to mention the pectoralis, of course, flexes the arm in the front. We got the deltoid, the trapezius, and the latissimus. Okay, those are your big movers. They do the heavy lifting. But inside we have these fine tuners, sort of like when we talked about the spine. There's those spine muscles nobody even talks about. Those are probably very important for spinal alignment, but we don't think about them. But we do think about these fine aligners because they're the ones that make us go to the doctor or the physical therapist or both. So what we see here on these bones again is that we have the humerus, the clavicle, and the scapula. Inside the anterior surface of the scapula or shoulder blade is this subscapularis. This will attach to the inside of the long bone and rotate your arm in. The other 3 are, as I mentioned, the supraspinatus, infraspinatus / teres minor. And let's just look at the cross-section coronally, just so we can get on the same page. Heavy lifter out here, the deltoid attaches to the acromion. Below that is the subacromial bursa. And below the subacromial bursa are the tendons of the rotator cuff. And right below that is the joint capsule. This is not a big space. Okay, actually I should say the ligaments and then the joint capsule. And it's not a big space, and we'll talk about that in a moment with impingement. So most people go see the doctor. This is injury number 1, and it's very interesting. You can tell where your rotator cuff injury is by self-testing. So what we see here is the anterior muscle that attaches on the lesser tubercle. If you put your hand behind your back like you're being handcuffed and try and lift away, even against resistance, it'll cause pain. This tells you that instead of being on the back surface, your tear is from the muscle that originates on the front surface, the inside of the scapula. Rotator cuff injury number 2 is the infraspinatus. You have them put their hand out at 90 degrees, flexion at the elbow like they're playing rock, paper, scissors, and then try and externally rotate the arm against resistance. Pain here is indicative of injury to the infraspinatus muscle and or tendon. This is causing external rotation. And we'll just forget the teres minor because that's kind of like the same thing. Finally, the third rotator cuff muscle, the most commonly injured one, is called the supraspinatus. This is the one on top. And you have a person do the empty can test. You stick out their arms here at about 30 degrees adduction, hands down like they're sending a gladiator to their death or whatever the direction is. And if they resist and there's pain, then you have damage to the supraspinatus, okay? That abducts away from the body. Okay, I mentioned impingement. Now, I mentioned, here's that diagram again. The space there is not great between the acromion, the roof, and everything underneath. And it normally does get impinged or made smaller by movement. So what's shown below here is when you have a bone spur, let's say there's an outcropping, it could be grinding, shaving, cutting that tendon and muscle, and that bursa causing impingement. Now, we'll talk a little about the treatments for this, but if you want to diagnose it, you have the person abduct their arm, put their arm straight up like that. If it causes pain, you might have impingement, probably too. Another test that works is have them reach across to the other shoulder, lift the elbow up to their eyes. That narrows the space. If there's pain, you have shoulder impingement. And what we really mean by that is this little bottleneck here between the acromion and what's below it is getting symptomatically pinched or impinged. So we're winding down here. The treatments are pretty much just fourfold. The best is to prevent. Don't get injured. Have good technique. When you feel pain, it's not weakness leaving the body. It's your body telling you it's getting injured and you should stop. So proper technique is very important, and exercise is very important. This will strengthen all the other muscles. The muscles, as you now know, stabilize the shoulder in many different ways. So we need to have proper technique, prevention, listen to your body. When you do get an injury, thank God, everything usually heals itself. Those stem cells copy. There's still enough capacity to do that. So things like physical therapy can teach you range of motion, flexibility, can strengthen, highly recommended. Your doctor may recommend it. Chiropractor, you can go on YouTube and just pick up some tips as well. The tincture of time usually heals all wounds, so that's what we treat it with. And even in orthopedic surgery, the dogma is to do conservative measures just because the ability to quickly fix without risk is limited, and orthopods know that as well. I refer you to exosome video number 5, where I give about a 40-minute history of the entire regenerative medicine field, and there's not much history there. There's basically prolotherapy, steroids, and then maybe prolotherapy again. Prolotherapy, hypertonic dextrose, sugar to poison the cells. The thought is damage will cause inflammation, which will make it stronger. So I guess it would be like getting calluses on your fingers from hard work. It's 3 steps back, 4 steps forward, let's say. And it's painful, but a lot of people in the last 15 years have tried prolotherapy with mixed and to positive results. I personally wouldn't do it. I think the idea of damaging something to make it stronger, maybe good for personalities, but not as good for joints. What we see here is the top just indicates what I trained 2 days in terms of technique to do, both by physical palpation, marking the skin, clinical exam. We can inject in the shoulder, both in the subacromial region, as shown with the lady, and then we have the injection of the glenohumeral joint. The ultrasound shows a needle going straight into that rounded head. And when you do this, I use both techniques. You inject, you see the fluid filling up that fine joint capsule. And so you know it's going exactly where you need it. If there is impingement and you do feel like you want to do surgery, the surgery is shown here in this bluish cartoon. The surgeon looks in and they take an instrument, and the burr removes that spur. Sounds great. You make more room in that tunnel, less impingement. But in fact, there was a study presented in 2016 in Barcelona, 132 patients. The long-term outcome was no different from physical therapy and surgery. The fact of the matter is, you know, if you need it, it might help. It's not that risky a procedure, although there are high rates of infection, but the long-term outcome may not be better than just having watched YouTube videos and doing exercise on your own. When, of course, the shoulder is beyond repair, let's say you have cartilage damage, arthritis from aging, you have tear in the labrum from trauma, you have rotator cuff tears or tendinosis, it's time for a replacement. And that replacement can take three flavors. The first is the total, where they replace the ball and stem and the socket. We have the hemi, where they just put the ball and stem. And then we have the reverse, where they put a ball in the shoulder, actually, and the cap, or this flat plate on the humerus. So some of you may be interested in exosome treatment. I should reiterate strongly that the exosomes are not FDA approved to treat shoulder injury. Now, having said that, nothing is FDA approved to treat shoulder injury that I know of. Certainly not steroids. There's never been a randomized controlled trial, but it is standard of care. But as we learned in my 2-day seminar on joint injections, steroids are chondrotoxic. That means they poison cartilage producing cells. They cause osteoporosis, and they could be cause weakness of the collagen, which the ligaments and tendons are formed of. So it's always a little bit of a Faustian bargain when you're injecting steroids. And so in my experience, 14 out of 17 times it's been positive, both in myself and my mom. We were the first patients. I'll talk about the failures first. There's 3 patients out of 17, and I've only been doing this for a year and a half in terms of clinical practice. But in those 17 patients, there's 3 who I would say not enough help. One, JP, we lost contact with her. It was a mild problem. I don't know really what happened. MC was a 76-year-old shoulder injury person. He played a lifelong rugby, and it was pretty trashed, and he was planning a shoulder replacement. He said it felt a little better after 2 injections, but again, not enough to stave off the surgery. Now he's very happy. We're happy to report that his shoulder works well after replacement. And then finally, a 38-year-old man, giant hulking guy, who used to swim with these paddles, and I think he did some serious damage, but the amount of repair that could be done with 1 subacromial injection was not significant. My first patient was actually my best patient. BH was a 51-year-old man. I've known him for many years. He's taken TA65. He came to see me after much due diligence on the internet, learning about all these modalities and having tried many things for 4 or 5 months. I think he tried therapeutic massage, different, rolfing, injections. Nothing worked. So he came to see me. We did the injection, and he got 60% better. Now, I thought, oh, I'm really sorry it didn't work. And he said, what are you talking about? It's 60% better. And I said, well, maybe next time. He said, yeah, well, next time is next month. I'm coming back. And I said, well, okay. So he insisted after his due diligence that 1 treatment was not going to do it. In fact, he was right. So the second treatment quickly got him to 100%. Before he couldn't lift his arm or lift baggage. And now he was able to play tennis and bench press 315 pounds. So he's very happy, so happy. In fact, he said, I want you to sell me the exosomes. My wife, who's a nurse, will give it to me every month as part of my anti-aging regimen, which actually is probably not that crazy. Another good story is VS, an actor who's 57, and he works out a lot as for his profession. And he said that since injecting both his subacromial bursa, he has, quote, never had shoulder pain that limited my strength training. TF is a friend of mine for many years who, right before I came to Hawaii, asked for a shoulder injection. He'd fallen a lot in Jackson Hole, damaged his shoulder. And so we injected him. And right now, 6 weeks later, no pain at all. And finally, LL is an 81-year-old man who drove all the way out and to see me. And we injected 5 billion into his right subacromial bursa. And his quote was, I don't know if the shot in my shoulder worked or not, but it is completely healed now. It's kind of funny. He had many, many years of shoulder pain. There may be an association, but he's quite right. His attribution is, of course, minimal, but it's probably not 100%. It probably went from 20% function to 50% function, and now he can play pickleball, and there's no pain. But is it 100%? He's probably not. He's probably wrong about one thing. It's probably not completely healed, but the shoulder was probably helped by the injection. On the right, we just see, again, what I would do if you came to see me for a shoulder injection. It's quite an easy procedure. We can use ultrasound, slight compromise in the sterility of that. It's really not necessary. I find that the technique is very easy once you have identified that union of the acromion and the J-hook, the acromioclavicular joint. You just aim for that gliding under the shoulder blade. It's quite easy. There's nothing in this area that can be damaged nerve and vascular wise. So, and you can feel it when you're in the muscle or tendon, there's more resistance. Arguably, it could be more effective, but it's painful to inject, and I don't think it is more effective. So I put it in the bursa, very low resistance, largely painless. When we go from behind into the ball or the glenohumeral, really what we're aiming for is the ball, and we could see the fluid injecting directly into that joint capsule. Again, I don't think it's at all very painful. It hurts a little bit when you tap the bone, but we're not going in there grinding around. And so it's very well tolerated, and it's a super easy thing, hard to miss if you know the landmarks. The landmark in this case is aiming for that knob, that coracoid process, and you hit it every time. Okay, so that concludes the shoulder webinar. I hope in the course of this you've learned a little bit about the anatomy. Again, prevention is super important. It's important to stretch those muscles, use them well, have good posture. There's many ways out before surgery in terms of physical therapy. So I hope you've learned a little bit about the anatomy, the most common problems that the shoulder encounters, and some possible hope in terms of exosomes. Does anybody have any questions? I'd love to answer them. I'll go ahead and close the presentation. And thank you for attending.